So good afternoon, everyone. I would like to thank ma'am for giving me this opportunity to present the topic here. Uh, so I'm going to present on role of muscles in thoracic and abdominal pain. So you must have all seen the muscle anatomy in the anatomy hall yesterday. I won't talk much in detail about it, but just the clinical significance. Here, how can I just remove the screen? Yeah. So here is basic anatomy of the chest region. You can see the big muscle in the chest region is the pectoralis major, which originates from the clavicle, manubrium sternis, sternum, and inserts into the humerus. Below that is the pectoralis minor and subclavius muscles. And deeper to that are the intercostal muscles, wherein we can see three layers of intercostal muscles: the external intercostal, internal intercostal, and the innermost intercostal muscles. The fascia covering the innermost intercostal muscles, that is the endothoracic fascia, is being attached to the pleura also. So we have to keep one thing in mind, that whenever we have intrathoracic lesion, so that time if pleura is being irritated, the pain may be reflected to the musculoskeletal structures in the chest region. So that explains our way of treating the patients of intrathoracic lesions with dry needling, Botox, trigger point injections, and other modalities wherein we target the muscles. The muscles in the abdominal region, anteriorly we have rectus abdominis, the two bellies of the rectus abdominis. Laterally, we have three layers of the muscles, that is external oblique, internal oblique, and transversus abdominis muscles. Posteriorly, we have quadratus lumborum, which originates from the rib cage and inserts onto the iliac crest, and the large muscle, that is psoas major, starting from the spine, transverse process of the spine, and inserting on the femur. And we have psoas minor and iliacus muscles. So these muscles carry a very significant role in stabilizing the spine, maintaining our gait. So whenever we give instruction to the physiotherapist for, say, for back pain patients, that strengthening of the core. So what all these core muscles indicate are, one very important core muscle is diaphragm. The other core muscles are quadratus lumborum, psoas major, and perineal muscles and transversus abdominis. So these abdominal muscles, they support the trunk, allow the movement, and they hold the organs in place, and they are very distensible because these muscles are very thin sheet of muscles which connect the rib cage and the pelvis. So these deep abdominal muscles along with back muscles, they form the core, and they help in keeping the body stable and balanced. They control the movement of spine, pelvis, and rib cage during the gait. Virtually all the actions that involve the all the actions involve abdominal muscle to some degree. Even when body is at rest, the abdominal muscles are working to keep it stable and balanced. So whatever activity you are doing, like walking, standing, or whether you are doing swimming, running, so in all those activities, your abdominal muscles are being used, and that's why we need to have very strong core muscle to prevent back pain, and to prevent certain other conditions like hernias. So one thing which we have to keep in mind is a single muscle does not usually work in isolation, but they're working in harmony with others. Like, say, for example, if you want to twist your trunk to right side, your left-sided external abdominal muscle is being contracted and right-sided internal abdominal muscle is being contracted. So both the sides are being equally affected if in pain related conditions. So rather than talking about anatomy again and again, I have included 4 cases wherein I can better correlate the clinical conditions with anatomy. So my first case is post-CABG pain. Here's a 62-year-old gentleman who underwent coronary artery bypass grafting with midline sternotomy scar for triple vessel disease some 6 months back. He complained of pain around the scar, which was burning and aching in type. The burning pain was constant and it was exacerbating intermittently. And aching pain was more so in the lateral aspect of the chest. In this region, he had aching pain, and it used to aggravate with the movement of arm. He was being given neuromodulators like gabapentin and nortriptyline by his cardiac surgeon, but he showed only partial response to those neuromodulators. So when I examined the patient, I could find triggers in pectoralis major and deltoid and biceps. His shoulder movements were all restricted, and he did have allodynia around the scar, especially in the middle portion of the scar. So in the OPD setting, uh, I did his first session of dry needling only around the scar region. So with first session, he had 50% relief in allodynia, but no relief in aching type of pain. From second to seventh session of dry needling, I did under ultrasound guidance. The dry needling was done for pectoral muscles, deltoid and biceps, and for neck muscles as well. And patient was sent for rehabilitation with physiotherapy exercises, and 2-year follow-up of that patient is available. Patient is pain-free. So now this is second case wherein patient is 28-year-old gentleman who complained of left-sided chest pain since 2 years. History of blood trauma to chest was present, but this history could be elicited only after uh, detailed history taking, which was not being elicited by other physicians and surgeons, which he had already visited multiple times. Uh, his pain was aching in type, NRS was 6 on 10. It used to aggravate with lying on the left side with deep breathing, and temporary relief was there with medications. So in medication, he was already being given NSAIDs, muscle relaxants, uh, and neuromodulators, some antipsychotics also. Uh, on examination, he did have tenderness over left-sided serratus anterior and mid-axillary line. All the investigations like chest X-ray, ECG, 2D echo, CT chest, local ultrasound were normal, and all investigations were normal. So he was being advised PET scan by orthopedic surgeon, and it was also normal. So he was being referred to a psychiatrist. But detailed clinical examination and history of blunt trauma to chest uh, did lead to certain diagnosis, wherein I diagnosed him as having myofascial pain syndrome of serratus anterior. So I decided treatment like trigger point injection under ultrasound guidance was given, which gave him 50% relief. Trigger point only at painful site were given. Other muscles were not being targeted. So he had only 50% relief, and dry needling sessions were done. Total 6 sessions gave him 100% relief in this patient. So in this patient, I did dry needling of serratus anterior here, latissimus dorsi dry needling was also being done, and paraspinal muscle dry needling was also being done. Few sessions were done under ultrasound guidance, and few sessions were done in OPD setup. So this is how, and the logic of doing other muscles also is one cause I have already explained, that when we are doing one activity, not the single muscle is being involved. Multiple muscle can be involved in performing single activity. The other reason for doing needling for other muscles also is the nerves originating from paraspinal muscle, nerves originating from the spine can also be compressed in the paraspinal muscles. So I need to focus on paraspinal muscles also, and there is anatomical connection between the muscles, like a thoracolumbar fascia being covering the multiple muscles. So if one muscle is being involved, the other muscles are bound to get involved. So we cannot focus only on one muscle wherein external trigger points are being present. If we do the needling under ultrasound guidance, multiple trigger points can be seen which are not being elicited externally with visual eyes. Externally visible trigger points may not be present in those cases. Third case is post-surgical pain. This is 50-year-old gentleman who was donor. He donated the liver to his wife. Surgery was performed 1 year back. Unfortunately, immediately in post-operative period, he lost his wife. The surgery was being done in big corporate hospital, so he had spent around 40 lakh rupees. So the life was being lost he had lost money also, and what he had got in return is the bad post-surgical pain. So he complained of pain all over the right side of abdomen. It was more so in the periscar area. It was pulling type, 10 on 10, no relieving factor. And this much history I could elicit because the patient had uh, all the negative thoughts like resentment, anger, grudges. He thought that doctors killed his wife, and in return he got the pain purposefully. So and he wanted us to treat him for free, which was not possible in corporate setup. 2 sessions of dry needling were done. Thereafter, no follow-up of this patient is being available. So I have included this case just to show that psychological history taking is also very important, because from that we need to we get to know how invasive in this patient we can go. And most of the times in such patients the pain is being exaggerated. If say patient has pain of 5 on 10, patient may exaggerate the pain to 10 on 10. So that is how detailed history taking is very important aspect of uh, history taking. So this is a fourth case wherein a patient was 50-year-old lady with uncontrolled diabetes. She has history of shingles 1 year back. She had burning pain, which got relieved within 2 months of onset of rashes, but now she is complaining of aching pain in the lower back, lower abdomen on the left side, which aggravates with sitting, turning sides in bed. On examination, I could see healed scars of the rashes. Tenderness was present in abdominal muscles, back muscles, and her spine movements were all restricted. So in this patient, as there was no burning pain, uh, as there were no electric shock like sensation, intercostal nerve block was out of question. So I had planned dry needling for this patient. And with 6 sessions of dry needling, she is absolutely pain free. So with all these 4 cases, my take home message would be muscles play very important role in all the pain conditions. If we apply the concept of neuromyopathy, which is being taught to us by Dr. Vas ma'am, so case solving becomes very easy in these cases. Detailed knowledge of gross anatomy and ultrasound anatomy is must. And if we take proper psychological history, we are more uh, we can decide whether how invasive we can go in these patients, because if patient has yellow flags and if we are doing some expensive intervention or very invasive procedure, then it is very likely that patient will not be happy with us, and books may not always provide answer to all the chronic pain cases 100%. Thank you.
Priya, thank you.